Good morning to one and all. Good morning. Let's thank God for leading us throughout yesterday's sessions, and especially we happen to reflect on many things. So let's continue to stay open and let us continue to stay fresh throughout the day. And especially today, we'll be looking at pain in the context of palliative care, which we'll be starting soon, and then the pastoral perspective, and then again the psychological perspective, and again the pain of the painless, led by Dr. Jerry. So without delaying, we would like to hand over the session to Dr. Reena George, the former head of Palliative, and may I invite Dr. Reena and to Dr. Stanley Macaden to please come forward to take the dais. And over to Dr. Reena.
Good morning, and thank you to Chaplaincy for this program and for giving me this opportunity. Dr. Stanley Macaden, the former director of the Bangalore Baptist Hospital, held one of the highest positions in the Indian Association of Palliative Care. He was the secretary of the association. But long before he belonged to Bangalore Baptist or to Indian Association of Palliative Care, he belonged to CMC. He's from the MBBS batch of 1963, before most of us were born. And his daughter, who is an alumnus of CMC, may be known to many of you. Priya Macaden is the General Secretary of the Christian Medical Association of India. Dr. Macaden will be talking to us about pain in the context of palliative care. As Sister Shakila had mentioned yesterday, the founder of palliative care actually had a very interesting vocational journey. She was studying humanities in Oxford when the war broke out, and she decided to train as a nurse. Then later, because of health issues, she became a social worker, started working with dying people, and she was close to 40 when she actually studied medicine and qualified as a doctor. It's hard enough to study medicine in your teens, so that was quite a feat. I think it was because of this multifaceted experience that more than many other medical specialties, in palliative care, one could recognize the physical, emotional, social, and spiritual elements of pain. And in the palliative care service that Dr. Stanley started in Baptist more than 25 years ago, emphasis was given equally on all of these, and I'm sure he will tell you more about that, right from how does that painkiller get into the patient in the last days, to how do we respond to questions like, have I got this cancer because of my sins? They're not separate dimensions. The second thing which struck me as I was thinking of Dr. Cicely and Dr. Stanley is that just like Dr. Cicely did much of her greatest work in the later years of her life, Dr. Stanley, who now by my calculation must be close to 75, is still involved in many leading roles in the association. He is the national coordinator for the Christian Medical Association of India's palliative care programs. He is, on an international level, the lead for Project India of the International Collaborative for the best care for the dying person, led from Liverpool in the United Kingdom. And many years back, in 2002, he started and continues to be the management convener for the National Fellowship in Palliative Medicine and Nursing. And this program, in fact, has trained many of the people who have led palliative care development in our mission hospitals around the country. So without further ado, may I request Dr. Macaden to tell us about understanding pain in the context of palliative care.
Thank you, Reena, for those kind words. And I want to thank Reverend Aruldas and the chaplaincy team here for this kind invitation. And it's always lovely to come back to Vellore. It's like coming back home. So thank you very much. And yesterday in group 2, I was reminded that I am the oldest person there. And this has continued. Even before that, I had an experience where I realized that I am getting old. When I was getting off the bus at the bypass here from Bangalore, I picked up a wrong suitcase. And so I want to thank Pastor Joseph, who is in control of all the buses in Tamil Nadu. And, by 2 o'clock, I got my briefcase with my laptop and everything. So I realized, yes, I'm getting old. And Reena also just emphasized that. Yeah, Reena, you were quite close. I'll be 76 in December. 75, correct. So friends, this is a wonderful symposium. I have learned a lot yesterday listening to various deliberations. I've learned a lot. And I think this is how we should approach any topic actually in medicine. We should have a collaborative approach, an approach where we treat the person as a whole, not just his heart or just his, physical ailment, but that we all, look into this kind of combined learning so that the benefit goes to the person. So I'm going to talk on understanding pain in the context of palliative care. That was the original topic that was given to me, and I think that is more appropriate than the topic that is put in this thing, pain management in the context of palliative care. Because we need to understand. We need to understand about pain. And yesterday, Dr. George Tarian did a wonderful job. I learned so much in that, the details of how pain is felt and how it is sensitized. So it was wonderful. So we need to understand the physical, the medical aspects about pain, the knowledge about pain. We also need to understand our own pain experience, because that helps us to understand the pain of somebody else, the pain of the person that we are ministering to. So that's what I would like to do today. How many of you been to Baptist Hospital? Recently or some years back? Because it's just kind of growing very fast, that's why. The picture on the right is in 1995. That is kind of midway when Vellore came into the governance of Baptist Hospital. And that is when we started our palliative care program. It was about a 100-bed hospital at that time. It was 80 beds when I joined in 78. And this picture here is how Baptist Hospital is looking now. So you couldn't even get a picture from inside the hospital. You had to cross the road and go to the other side to get this picture. So you know how much it has expanded. And we are now a 350 multi-specialty hospital, but with the addition of radiotherapy, we are also a comprehensive cancer center. So for a mission hospital to be a multi-specialty hospital plus a comprehensive cancer center is nothing but God's doing. And that's the emergency. And we are right on the national highway, so that has become very important. So as I said, I want to talk about understanding about pain. We'll look at what is palliative care. We'll look at understanding and responding to pain and suffering, especially of someone else. And I will just briefly give you the BBH model of integrated palliative care. So let's look at some perspectives. Here's a poet, John Dryden. For all the happiness mankind can gain, excuse me, is not in pleasure, but in rest from pain. Albert Schweitzer, we all must die. But if I can save him from days of torture, that is what I feel is my great and ever new privilege. Pain is a more terrible lord of mankind than even death itself. He was also a theologian, but I'm not sure about his theology. But this appeals to me as a physician, that pain, somebody's pain, I must address. First of all, I must believe he is having pain. So a lot of times we doctors think, he's not really in pain. Every time he's talking about the same thing, he's got some psychological problem. But we must believe pain, and that we must do something about pain. And otherwise, it is a terrible lord of mankind. Yesterday, Dr. I don't know his name, mentioned about C.S. Lewis, who went through this whole thing about pain, and has written, there's a movie, and he has written books about it. And one of his statements is, God whispers to us in our pleasures, speaks in our conscience, but shouts in our pains. It is his megaphone to rouse a deaf world. The question is, are we listening? In India, the palliative care coverage, when I started 27 years ago, was around 3%. It is still around 3 to 5%. So there's a huge need. There is a magnitude of suffering. There is a loud, deafening voice which is asking for help. Are we responding? We looked at those perspectives. Here's the perspective from a patient. A patient says, I found that when I didn't have pain, I thought I didn't have cancer. He knows about cancer, but when his pain was reduced, when that terrible pain was reduced, he felt he's, normal. He's not having cancer. And this one is a very striking statement. It was made by a cancer patient called David Tasma to Dame Cicely Saunders, which Dr. Reena George mentioned. I want what is in your mind and what is in your heart. I want your knowledge. I want everything, all the details you know about how to manage pain. But I want what is in your heart, how you feel for me, how you deal with me as a person. Oh, sorry. Okay. Sorry. So, there's a big, long definition about pain, but in simple terms, I want to say pain is what a patient says hurts. Get hurt? Yeah, that's what is pain. Pain is a somatopsychic phenomenon. In other words, it's not only a physical kind of pain, but also there is emotional aspect. So, somatopsychic phenomenon. And perception of pain is modulated by a patient's mood, morale, and meaning of pain. So, when you're sad, when you're worried, that simple pain which was there seems to be even more aggravated. Yesterday, George Tarian also talked about sensitization, And what is this meaning of pain, Let's say you have a family member who's gone through cancer and who had not a good death, he was struggling, he was a lot of pain, severe pain. Then your experience, or also the experience of the other family members, is colored by that. For them, the meaning of pain is severe pain, that terrible distress, the suffering. So that is what we call meaning of pain. What does it mean for that person? So these are the things we need to keep in mind. And in this diagram here, what is important is that what we see is pain behavior. You have the stimulus in the center, the pain which causes the pain. Then you have pain. And as a result of that, there is suffering. But what you see is pain behavior. The pain is, person is depressed, is sad. I'll be leaving this presentation here with Pastor Aruldas, so you can use it, so you don't need to make detailed notes. Pain classification. I don't want you to be, worried about the medical side of this, details of it. It's enough if you remember what is acute pain and what is chronic pain. Because often the problem when we visit people in their homes or when they come to our clinic, we have told them to take, let's say, for example, morphine. Morphine has to be taken every 4 hours. After 4 hours, there is no morphine in the body. But that is how, because we manage chronic pain. Chronic pain is pain which is there almost every day or most days of the week. Whereas acute pain is once a week or once a month, you have a toothache or headache, and you take a paracetamol or whatever. Okay? But when you have chronic pain, you must take medication regularly depending on the action of that medicine. If it is paracetamol, maybe every 4 to 6 hours, or if it is diclofenac or something for bone pain, it has to be taken every 8 hours or every 12 hours if it's a long-acting drug. So like that, so this is where you can help. When you visit a person in the ward or in the home, just find out, how is he taking the medicine? Is he taking it according to what he has been told? Nociceptive, neuropathic, all that, we don't need to worry too much. Physiological, somatic, or visceral. Somatic meaning, the body pain, the musculoskeletal kind of pain. Visceral is, from the inside, from the organs, okay? Another important classification is opioid responsive. A lot of pains they respond to drugs like morphine, but some are resistant. For example, the skeletal muscle spasm, it will not respond to morphine. You need to give a muscle relaxant. So, just by talking to the person, you'll be able to find out, and you will be able to find out and also know that he's taking morphine regularly, but it is not helping. So you can convey that to the team. We all need to work together as a team. Then only we'll be able to help these people. So don't go into too much detail. It is there for you. For example, when you look at the first the column there, nociceptive, it can be physiological or pathological. In other words, functional or organic. For example, a simple headache, can be what we call a functional pain. At the same time, on the other side, it can be due to a brain tumor. So that's a pathological pain. Okay. So in the same way, the others are there. I won't go into the details. What we need to also know is, what are things that will lower pain threshold? In other words, if you have any of these conditions or they're acting on you, then your pain is increased because your threshold has gone down. So any discomfort due to anything else, any other symptoms, okay? Sleeplessness, fatigue, anxiety, fear, anger, boredom, sadness. Yesterday in our discussion, we realized that loneliness is the biggest disease now. So when a person is lonely, that pain gets aggravated. Social abandonment, okay? Mental isolation. So all these things will lower your pain threshold. On the other hand, aspects that raise pain tolerance. So this is what we, as chaplains, as people helping the person in the ward or in the home, these are things you must try to emphasize, that take your medicine so that all your other symptoms, if you have nausea or if you have constipation, that is taken care of. Help them to sleep well. Help them if they need some physiotherapy. Or, always the family says, no, you must stand up and walk and do this. Let their body decide. If they need rest, let them rest. Okay? So there are relaxation therapies, explanation. Often we doctors nowadays don't have time. We are looking at the MRI screen and all the investigations. We don't even touch the patient. We don't explain things. But when we do that, even if we cannot do anything about that pain, the person begins to feel better. That's just simple explanation, talking, feeling, touching, all that. So all these things, elevation of mood, understanding of the meaning and significance of the pain for that person. So when you go into those kind of details, the person feels that he can handle the pain. Also, pain in advanced cancer does not mean that every cancer there should be pain. 1/4 of patients may not have pain at all. They may have cancer, but may not have pain. I think for some hematologic or blood cancers, they may not have pain. They may have bleeding and other problems, but may not have pain. Also, it's good to remember that multiple concurrent pains are common, and 1/3 of patients may have just a single pain, maybe a headache or maybe stomach pain, but another 1/3 may have two pains. You have a brain tumor, but you also have gastritis. Or another 1/3 may have 3 or more pains. For example, they may have osteoarthritis and knee pain, but they also have tumor and gastritis. So by talking to them, we can find out what is the cause of that pain. And the causal categories are usually 85% is by the cancer, another 17% is by treatment, and another 9% is related to the cancer or the debility. They're very weak, and as a result, every effort that they make is painful. And then by a concurrent disorder. Like, for example, it may not be cancer at all. It may be a gastritis. It may be an osteoarthritis. Yesterday, I think I was not here, but Sister Shakila would have gone through this pain assessment. And it is very simple. We have it as PQRST because that's what the doctors remember, the cardiac impulse is in the echocardiogram, in the cardiogram we write it as PQRST. And so we start from bottom and go up. That is time. That is it continuous pain or is it intermittent pain? Where is the site? And does it move to some other place? Does it radiate somewhere else? What is the quality of pain? Burning, pricking, whatever, ache, whatever. And then how is it? Is it precipitated by something or is it relieved by something? So those are the details we try to go into. Yesterday, Dr. Tarian did go into all that in a very nice way. And also yesterday, I think Shakila would have talked about this assessing the intensity of the pain. So what we usually use is a 0 to 10 numeric pain scale, and where 0 is no pain and 10 is unbearable pain. And then you have to explain that to people who don't understand this kind of a scale. You can say, in 1 rupee, how much pain do you have? 50 paisa, 25 paisa, whatever. And once they understand that, next time when you go and talk to them, they say, yeah, now only 25% pain is there. So you know that you're getting it through to him, and you know that they're taking their medication properly. So then, now let me come to palliative care. What is palliative? This is a very simple definition, not the WHO definition, which has been revised a couple of times. It is holistic care. Holistic care of people facing a life-limiting illness to improve their quality of life, but not only quality of life, but also quality of death. There's no point taking care of a person very well, till the last few days, and then nobody is there to manage the last bit, because that is what the family will remember. So quality of life and quality of death, and to also help their families to cope. This is very important because in a terminal or prolonged illness like this, it is also the family which goes through a lot of suffering. So in palliative care, the person and family are the unit of care. And we all realize that palliative care is a good platform to practice holistic care. So let's look at the conditions requiring palliative care. Palliative care started in the context of cancer care. So yes, that's number one, incurable cancer. But now we realize that there are so many non-cancer conditions which need palliative care. And this is all the end-stage chronic medical disease, heart, lung, kidney, HIV/AIDS, or advanced neurological diseases, multiple stroke, Parkinson's, motor neuron disease, all these things. Also in the COVID time, we were seeing rapid deterioration and death. So there is a place there for helping the family, helping the person who's dying, working along with the intensivists for this kind of patients. Long-term care, yesterday, you talked about the person who fell off the building site. Yes, so many buildings are coming up everywhere, and we don't have really standards of safety, and neither do we help people who fall like that. So who takes care of these people who need long-term care, who are paraplegic, and also elderly with physical and cognitive frailty. This is the biggest group in the years to come that will need good palliative care, And these people, a lot of them are lonely, a lot of them are being abused by their families. So when they have a sensitive, good team, of a doctor, nurses, and a social worker or chaplain visiting them, it's like coming back into society for them. And so it relieves their pain. So palliative care is a person-oriented care. The disease doesn't matter, because the cry of people who are facing a life-limiting illness is the same. Help me, listen to me, stay with me, remember me. And to begin with, a lot of help is needed. That's why palliative care has to be a multi-professional, a team approach. And when we do that, when they are comfortable, they want to talk. They want somebody to listen. But nowadays, who's there? In our own homes, all of us are having food at different times. We don't come together as a family. We're not there to listen to one another. So they want somebody to listen to their highs and lows, their achievements in life, their fears, their concerns. So all that they want to talk about. And then later, as they get weaker, they won't even be able to create a smile on their face. Maybe with their finger they might say to sit with them. They just want you to be with them. Be a human being, not human doing, being there with them. And then finally when they are gone, we learn such valuable life lessons from these people. The way a person takes care of his loved one, You ask yourself, will I do this if my wife goes through this, or if my son goes through this? How will I respond? So you learn valuable lessons. It helps us to be a person, a good human being. We gain more than what we give, in this kind of situation. So, yeah. So that's Dame Cicely Saunders. And remember the date there, 1967. That is when she started this modern palliative care movement, and WHO came into the picture in 1987. 2 decades later, WHO woke up about this. But look at her, she started this, and the picture on your left here, and the statement here, it summarizes what palliative care is all about. In the picture on the right, who do you think is in control there? The patient or the doctor? Not like our ward rounds, where all of us are in white coats and one lot is standing here, the seniors, the juniors are on the other side, and the patient is going like this. Like Wimbledon, I'm exaggerating, yeah, but giving people control, like in this picture, she's towering over the doctor is a little scared. And that's Dame Cicely Saunders with one of our earlier patients. And the multicolored cover, the sheet, is to represent multi-professional team. Multi-professional team, keeping a person comfortable, giving them control till the last breath. Not saying tomorrow you have to go to this ward for chemotherapy, or the family takes over, and they are just asking the patient to do what they have worked out. They don't even tell the diagnosis to the big. Often they come to us and say, we haven't told them, like that. So they are in control. The patient has no control. Look at the statement. You matter because you are you. You matter till the last moment of your life. And we will do all we can to not only help you die peacefully, but to live until you die. It's a very honest statement. It's a very frank statement. It's a statement of commitment. It's a bold statement. And it should not be just a statement to be quoted, This is what every person who is practicing palliative care should be able to say to the person who he is treating. When we say, I will be till the last moment of your life, and if you don't have home care, and you have not empowered the family, what's the point? You're not being true to that statement. It's only a statement. It's not something in action. Just to give a little knowledge about this, palliative care is derived from a Latin word called pallium, which means a cloak or a cover. And we saw that, the cover, multicolored cover. So symptoms are cloaked with treatments, the primary aim of which is to promote patient comfort. And to palliate means to alleviate or mitigate or reduce. You will also come across the term hospice. Now, hospice and palliative care are terms used interchangeably. In the US, when they say hospice, they mean home care. In the UK, when they say hospice, it's usually you're in a building, it's a building. So WHO prefers the term palliative care. And it is a philosophy of care which emphasizes and values the quality of life and death, and wherever it is practiced, whether it's at home, whether it's in a building, in the institution, or in a hospital, or in a hospice. But let us look at this aspect of covering, and other perspectives in that. In this picture, you can see in the Indian context, we put a shawl or a panadai to honor a person. We have been doing that yesterday also here, a shawl around the person. From a Christian perspective, it's so important to understand what God is telling us. Christ clothes us in his righteousness. In Isaiah 61:10, we read, "For he has clothed me with garments of salvation and arrayed me in a robe of his righteousness." Wow, that's a wonderful meaning, wonderful emphasis that we can have, that we are not only there to reduce their pain and cover it with symptoms, cover it with treatments, their symptoms, but we are also there to cover them, to robe them with the garments of salvation. And then Paul in 1 Corinthians 15:53-56 keeps talking about, like, the perishable is clothed with imperishable, mortality with immortality. Wonderful, isn't it? And Christ is the only person who has won victory over death. And so these are the things which should help us to be bold, to be there with people, to help them in this difficult journey. It's also important for you to remember, the three main trajectories. Trajectories mean how the disease progresses and ends, okay? So the blue line is the cancer trajectory. In other words, it goes on fairly okay for a while and then a rapid deterioration. The blue dotted line is what we call the organ failure. You have a lung problem and you get admitted to the hospital, you get better, and like that you keep improving, getting better for that incident, and then you're back home. But it's still a downward course, but it takes time. And the green line is what we call the physical and cognitive frailty. In other words, the older people, especially dementias, which can go on for 8-10 years. So, and if you draw a box at the bottom, at the extreme right here, that is where palliative care needs to come in. According to WHO, it should come in earlier, but at least that's where it needs to come in. And this is what is seen in this slide here. Don't worry if it's a busy slide and you can't understand. The extreme, this is showing the continuum of palliative care, okay? So the extreme box there on the left is the pink box. You're in the pink of health, so to say. You have a healthy lifestyle, preventive care, everything is going on well. But then let's say you have a fracture or a heart attack, you need curative treatment, and after that, there needs to be rehabilitation. So those are the usual order of things. But then let's say, unfortunately, there is a terminal or incurable illness. And according to WHO, palliative care must come in as early as possible to the diagnosis, even when rehabilitation and curative intent is going on. Because as time goes on, palliative becomes more and more, and curative and rehabilitation becomes less and less. And also, as time goes on, in the UK, they take it as 1 year, but in our setup, it may be last weeks or months, That's where people are beginning to deteriorate. And that's what we say, approaching end of life, so that we can look into all the life closure measures. And this is by the GMC and the Gold Standards Framework, GSF, and the NICE guidelines. According to them, they have given guidelines for how do you make out that a person is approaching the end of life. And then finally, the end of life is the last 48, 72 hours, where there's actively dying, the person is actively dying. And that is where the International Collaborative for Best Care for the Dying Person, they have done a lot of work, and all that is coming in. And then palliative care continues as bereavement support for the family. Because, when there is an incurable illness, one person is affected, but 4 or 5 family members are also there. A young person is there, a mother is there, different people, and they're grieving differently. So unless they are supported, these 4 or 5 people, if they're supported and if it's a good death, they can be used as resources in the community to help others. But if the death is bad, then they remember only those terrible days, and then they themselves need help, psychiatric help to come back. And that's what Dame Cicely Saunders mentioned. How people die remains in the memory of those who live on. So achieving a good death is very, very important. So palliative care is right throughout. You don't have a second chance. You have to get everything right as much as possible. And therefore, you need to be good, competent in communication. You need to be good, competent in symptom management. And that's what this next slide shows, the 3 essential components of palliative care. Whoever you are, you may be a chaplain, you may be a social worker, you may be a doctor, you may be a nurse, whatever it is. The important thing to remember is these are the 3 most important things. That's why it's an equilateral triangle. In other words, symptom relief is as important as psychosocial and spiritual support. All that is as important as teamwork and partnership. And the common thread which keeps everything going is communication. Without good communication, everything falls apart. It's like the Tower of Babel, isn't it? They started, nobody could understand each other, and everything fell apart. So that's what happens. But it's important to remember what is the aim of all this. Finally, the aim is empowerment. Empowerment of patient and family. Why? There is a potential to care already there. God-given potential for each one of us to care for ourselves, to care for our loved one. That potential is there. We just have to harness that and use it and empower them with some measures that can be helpful. So we are talking about pain. Okay? Yes, pain is a very important, significant symptom. But more than pain is what we call weakness, fatigue, or no energy. So that is a more common symptom than pain. And in the bottom of here, I've also mentioned malodor. When you have pain, your loved one will come close to you and help you and assure you that they're doing everything for you. But when you are stinking, when you are having maggots and nobody comes near you, even the family members keep going. Dr. Rina George has done a lot of research in this whole area of malodor and maggots and things like that. And so for that person, that symptom of malodor may be more important than pain. So, yes, we need to keep pain in mind, but there are so many other symptoms. And towards the end, in the last few days, these are the symptoms. One common one is what we call a death rattle, gurgling sound from the throat, because the person is not able to even swallow their saliva, and it pools there in the mouth, and as they breathe, it creates a gurgling sound, and that is very distressing for the family. So just explaining that the person is not suffering, and we will see how we can reduce this gurgling sound, but he's not suffering. That assurance is very, very important. So all these symptoms are there, and we have to look at a few symptoms which we can manage at the end and teach the family how to do that. And those are mainly pain, agitation, in other words, they're restless, they're trying to jump out of the bed and things like that, confused, and retention, like maybe urinary retention or constipation. Okay, like some interaction, some myths and facts about morphine. Morphine used for pain will result in addiction, yes or no? How many for yes? Well, all are very clued, I must say. Yes. You want to express why? Or it's okay? Okay, but most of you know, or you have been told that morphine does not, when it is used properly, does not result in addiction, because person is taking morphine for his pain. He is not taking it to get high. That is a different story. Okay, so morphine should not result in addiction, normal morphine that we give for people. And India is one of the largest producers of legal morphine, yes or no? How many for yes? So actually, India is one of the leaders, largest producer of legal morphine in the world. There are some other countries like Afghanistan and the Golden Crescent and Golden Triangle, Burma, Laos and Thailand, that is the Golden Triangle, and Afghanistan, Pakistan, and one more, Iran, Afghan, Pakistan, and Iran. They produce, that's the Golden Crescent. They also produce a lot of morphine, but it is illegal morphine. India is one of the largest producers of legal morphine in the world. And yet, we don't have oral morphine, which is what WHO recommends. Simple oral morphine given every 4 hours, can take care of pain of people. For nearly more than 90-95% of pain can be managed like that, as long as the person is able to take orally. Okay, morphine is usually given by injection, intramuscular or intravenous. Yes? Is there any other way? I mean, orally, of course. There is a way of giving morphine, or in fact, many drugs can be given like that, and that is the subcutaneous route. In other words, you just put a small butterfly needle under the skin and leave it there. And whatever medicines, injections, combinations, whatever you want to give can be given by that. A subcutaneous route is as good as the IV route. It may take a little longer, maybe 10 minutes longer for it to act, but it is just as good. Oral morphine is easily available for pain management. I think we have already answered that. It is not, because a lot of restrictions were there, but the government has revised these narcotic laws, and what you need to be is to be a recognized medical institution, and there's a format for that. And once you do that, then you don't need a whole lot of other licenses, and you can get oral morphine. Okay, morphine is useful drug for constipation. you will realize when you're managing especially older people, that constipation is a huge problem. You take care of constipation, 50% of your problems are solved. Okay? And morphine causes constipation. It's not a drug for constipation, it causes constipation. Even the the King of England is not exempt from that. Okay? So when you take morphine, you have the same hand must write the laxative. Okay? Morphine will always cause respiratory depression. This is what we learned in our medical school, that it does cause respiratory. Yes, if you take a big dose and you've never taken morphine before, you're naive to morphine, then yes, it can cause some problem, but not the way it is done in palliative care. All kinds of pain will respond completely to morphine. I told you in the beginning that skeletal muscle pain does not respond. It is resistant to morphine. Morphine can help in breathlessness. Just now we learned that it causes difficulty, respiratory depression. But yes, now they have realized that morphine helps people to cope with that breathlessness. A smaller dose, but given regularly, helps people to cope with breathlessness. Any guesses? In Kerala also we see a lot of this terrace gardening, terrace cultivation, also in the northeast, every place in India. What is being grown? Does this help? This was the white variety and this is a pink variety, and you can see the flower and the pod. And it is by scraping on the pod that you get the crude extract from which morphine is made. And I have already explained to you, see the one in orange there is India, the legal producer of morphine. All the things in red are illegal. The golden crescent and the golden triangle and golden crescent. Yes, now it was Dame Cicely Saunders who first brought this concept of total pain. That is, pain is not just physical, it is physiological, it is social, and it is spiritual. I won't go into the detail because this has been expressed by a lot of speakers yesterday also. So spiritual pain, all the why questions. Why is God doing this to me? I've been a good person. Why am I suffering like this? Is there any meaning and purpose in life? Also, sometimes the need to be forgiven or need to forgive somebody is a very important aspect of spiritual care. And when we do that, when we mend those relationships, suddenly the person is peaceful. So total pain needs total care. And that is what Dr. Twycross prefers this diagram to another diagram where you can put another circle and say spiritual. But in this diagram, what we are emphasizing is that the spiritual dimension is the all-encompassing dimension. The soma, physical, psyche, and social, but spiritual is the all-encompassing dimension from the beginning till the end. So, yes, it was, I spelt it with a W, W-H-O-L-I-S-T. Holistic, if you write like that, your computer will not allow you. The red line will come, okay? So then what is holistic care? Is it holy care? Is it care with holes? It's derived from the Greek word holos, which means the whole is more than the sum of the parts. The whole is more than the sum of the parts. For example, H2 plus O is H2O, 10 out of 10 for chemistry. But it is more than that. It is water. It's life-giving water. Sodium plus chloride, you can say sodium chloride, but it's more than that. It is salt, without salt, which makes all the difference. And the same way, body, mind, heart, soul, and spirit is what constitutes the whole person. So palliative care is holistic care. And these are the members of the team, patient and family, are the unit of care, the physician, nurse, chaplain, social worker, and then others in the setup, the therapist, the pharmacist, the occupational therapist, the physiotherapist, and then the community resources. In the community there are so many general practitioners. We need to make use of them, and also the church community, the volunteers in the church. And if we can do that, then we have a wonderful team. And the reason for getting the community involved is this fact that many of the problems in advanced disease are of a non-medical nature. In other words, it's about 30% is only what the doctors and nurses can do, the physical side of it. The financial, social, psychological, the spiritual, all these can be handled by the community. 70% can be done by the community. And this is what this quote also says, volunteering is the ultimate exercise in democracy. You vote in the elections once a year, but when you volunteer, you vote every day about the kind of community you want to live in. And this has been practiced very nicely by the Neighborhood Network in Palliative Care, NNPC in Malabar, where you can see this whole hall full of volunteers, for a conference that they're having. So in palliative care, the emphasis areas, priority areas are good quality of life and death, family to be supported, holistic care for total pain, and also looking into aspects of comfort, dignity, peace, and hope. And finally, bereavement support. And so what is the need? Why do we think that this is so much important to have palliative care in your setup? 60% of all deaths could benefit from palliative care. Based on population-based studies, 60% of people could need palliative care. So when this is not there, you can imagine how many people are suffering unnecessarily. And in the Indian scene, the population of more than 1 billion, which is 1/6 of the world population, and with a crude death rate of 8.28, about 9 million deaths every year. And out of these 9 million deaths, nearly 60%, roughly, you can say 54 lakhs could benefit from palliative care. And what is the current situation? The Indian Association of Palliative Care, IAPC, started in 1994. About 90% centers which provide palliative care are in Kerala. Those who need palliative care, maybe less than 3% or 5% now get it. Though the Act has been amended, health is a state subject, and many states are still dragging their feet. Morphine is not available. When you look at the mission hospital situation, only about 10%, 30% of 30 hospitals out of 300 have good palliative care in the CMAI hospitals. This was an organization in Singapore which did this assessment of palliative care. They first studied 40 countries which had palliative care, and they ranked them according to this quality of death index. And in 2010, our rank was 40 out of 40. In other words, the paper said we are the worst place to die among 40 countries. After another 5 years, this time they looked at 80 countries. And on the right there are the countries which are at the top, UK leading. And then on the left are the countries, the last 15 countries, and India is 67, almost leading those. And then they have done it again after another 5 years in 2020, and now the rank is 59. So there is improvement, but still a long way to go. And this is a very, very important statement by the Human Rights Council. It says, denial of pain treatment is a form of abuse in healthcare settings that may tantamount to torture, or cruel, inhuman, or degrading treatment or punishment. So denial of pain treatment, not just physical pain, but the whole holistic approach to pain, if it is not there, it is like abuse, it's like torture. And this sometimes is what is happening in our intensive care units, because especially where money has become the important thing to pursue. And people are unnecessarily put on ventilators, and that is definitely torture. So why should Christian healthcare missions be involved? Well, it fits in with our ethos, our vision, our mission. It's an excellent platform for holistic care, excellent opportunity to witness for Christ, excellent opportunity to make His healing and wholeness available. And so briefly, can I have another 5 minutes? Yeah. BBH model of integrated palliative care. We started in 95, And it is integrated, meaning it is part of the hospital, one of the departments of the hospital, and it is taking care of cancer, non-cancer, and it also combines with other specialties to do some combined clinics. It also does inpatient care, home care, outpatient care. We have urban teams and rural teams. We have bereavement support. We have volunteers' involvement. We have training of various courses, and also research and advocacy. So these are the motivating words for this. And our vision is restoring wholeness in people with life-limiting illness in the spirit of Christ. And that's Wake Forest University Baptist Medical Center, which came forward to support us initially. And that's the home care thing. I just want to tell you about this emblem. This is the emblem we have for palliative care, which shows the flower of the opium poppy. So it helps us to talk about morphine. But also you have the pod and a little cross on it, which signifies Christ, the chalice and the cross. So morphine in olden days was known as God's own medicine. And now we have this other appearance of the chalice and the cross, appearance of chalice and cross representing Christ, God's own gift. So God's own medicine, God's own gift. And the yellow rays of hope, and the hope is that I came that you may have life, life abundant and eternal life here now and hereafter. And the green leaves also signifying new life. And so that is the team. We have the mission, the base mission hospital, and then the next box is what happens in the hospital. Then on the right is what we call the multi-pronged, multi-professional approach for home care. And then if the person is more than 25 kilometers, we tie up with a social worker or a doctor, nurse, and do what we call remote supervised care. And finally, bereavement care. So I won't go into this, just a few pictures to show. Right back in 2000, we got a Best Poster Award for that. And that's the team getting all the bags ready. It's good to be the photographer here. And the team now with better vehicles, and the rural palliative team, and the homes, whether it is in the urban or rural, the poor are very poor everywhere, and it is really nice to see if we can make their last days comfortable and hopeful. Here's the pastor. So even when there is a crowd, you can still have that one-to-one connect, And we always pray with their permission. So that is something to keep. And Dr. Ravi doing even some difficult procedures can be done at home. And another poster award. So just to give you a little idea of the chaplain's role, get to know the family. In palliative care, we always have this thing called family tree, where anybody who sees that, it's a pictorial representation of the family. We know who's the person, who are the caregivers, and their important details are there. So know the family, encourage frank communication within family. Often you will realize that they haven't told the person, so you slowly try to help them. The doctors and nurses will also, what they call break bad news, but you can support that. You can make sure that they are having frank communication. Encourage medication being taken as instructed, whether taking regularly. Be a good observer. When you go in there, you can see the person has got, it looks depressed, or there is a lot of smell, So all that you can report to the team, and then explore the wishes of the patient. What does he want, Explain to the family not to force feed. Often they force feed and then it results in aspiration and cough. Provide spiritual support. That is very important. And that should be done with their permission. First, help them to find strength in their own faith. And if they are wanting to know about what gives you strength, you can share and pray with permission. And this is what I want to finally end with, what we call the family driver. In the UK, when a person cannot swallow, he's given in a 10 ml syringe a combination of medicines for pain, for restlessness, for vomiting in a syringe driver, which is shown there. That is very highly technological. A lot of alarms will keep going off. It needs a lot of training, and also it is expensive. Whereas in India, we cannot do that. So what we do is, instead of taking orally every 4 hours, we teach the family to give a combination of these medicines, same 10 ml syringe, but inject 1 ml of this every 4 hours, and also in between as needed. And we are able to keep the patient comfortable. So that is the, so I'm just showing some difficult cases here, severe pain, smell, everything. Here the wife is taking, it's all happening in the same visit. Wife is giving the injection, and our man is now sleeping, resting, but the wife wanted a picture taken, so he's woken up. In other words, it's not deep sedation. It is just enough to help the pain, and that's the family. Here, this man is all fully empowered. He's able to open the ampules and load the syringe, especially over the weekend. We don't give more than a couple of ampules, so wife being taught. And so we teach the family. And also we have this national fellowship in palliative medicine and nursing. In that also, here is a senior Dr. Jacob from St. Stephen's who was doing this course. And he was really surprised how people can be so comfortable with the laryngeal carcinoma at home. This boy, very distressed with, again, a sarcoma and these big secondaries in his, on his scalp, and also his lungs were full of this. He could barely breathe. And with the subcutaneous medication, he was able to slowly sleep and lie down in his mother's lap like this. And apparently after a few days, he died like this, sleeping in his mother's lap. And that was a big consolation for her. And that's the trainees being taught. So we have this, what we call the bereavement support. The last part of the bereavement support is an annual memorial service where nearly 60-70% of people whom we have invited come for it. And this is in the early days in our chapel, and now we have it in our auditorium. And that is our 25th Silver Jubilee celebration. So friends, 2 roads diverged in a wood, and I took the one less traveled by, and that has made all the difference. Yes, when we take this road which is less traveled, it does make a huge difference for the people we are caring for, and also for the institution that we are working, and also for ourselves. And we talked about hope yesterday. Yes, we say man lives with hope. Can he die with hope? There's a nice positive statement here. Death is not extinguishing light. It is putting out the lamp because dawn has come. I'm sure there is a lot of Christian thought that has gone into this. Our Christian hope is our hope in the Lord Jesus Christ. It is the living hope that we have. And we have those verses here which are able to give us that hope. And our motivation and guidance is from what Jesus said in the Sermon on the Mount: you are the salt of the earth, you are the light of the world. Yes, Jesus' love compels us to be competent, compassionate, and committed in serving the suffering and dying, and helping them to die peacefully with dignity and hope, the hope of eternal life. So in conclusion, to respond to suffering, there is no greater motivation than Jesus Christ. Jesus' love and compassion compels us to act. Jesus understands our suffering as he is the wounded healer. Jesus weeps with us when we weep. Healing and wholeness is available only in Jesus. Jesus has conquered death. Jesus restores our dignity and gives us peace. He gives us hope of eternal life. So friends, in palliative care, as Christians, when we are working, let us give Jesus to a dying person. Thank you.
Thank you, sir, for giving us both a macroscopic and an individual view of what all palliative care encompasses. There would be many questions, I'm sure, but since it's the first session of the day, we don't want to run any more late. But please feel free to talk to Dr. Macaden, including about the training programs and the services offered by CMAI. I will also, some of you might wonder, what can you do when you see a patient? I will send the organizers links to palliative care directories, places that provide palliative care, and couple of palliative care helplines in India, which patients or healthcare professionals can contact. So I hope that will be projected sometime, and I hope you will take the opportunity to learn from the wealth of Dr. Stanley's experience about how you could take this forward. Huh? Thank you, sir. Thank you.
These are some websites you can look at.
Maybe this once more, shall we give a big round of applause to Dr. Reena and Dr. Macaden. May I request you to please stay back for a minute. We want to acknowledge your presence with us. And as a token of love, may I request Dr. Prabhu to please come forward and honor our resource person, Dr. Stanley Macaden, to wrap a shawl and to share the shield. Thank you. Thank you so much. And Dr. Prabhu, may I request you to honor, please, Dr. Reena for moderating the session. Thank you so much. Thank you so much. Okay, let's move ahead with our next session.